Good day, students. Welcome to NURS 245, Nursing Practical 2. In this session, we are going to look at assessments of a patient. My name is Mrs. Cecilia Eliason from School of Nursing, University of Ghana, Legon. To perform an effective physical examination, certain equipment and techniques are required. The aim of this session, therefore, is to equip students with knowledge and skill for carrying out physical examination from head to toe, assessing pain as well as other measurements including weight, height, and blood pressure. This will permit students to recognize patient health problems and plan nursing intervention appropriately in the clinical or field practice. The key topics to be covered in this session are history taking, physical examination from head to toe, checking blood pressure, checking weight and height, and finally assessing pain. For your reading list, we have Annaman, Rekha, and Jade have 2008 Clinical Nursing Procedures, The Art of Nursing Practice by JP Brothers, and then Latte, Tips on Practical Nursing Procedures, and Bickley, 2003 Guide to Physical Examination. History taking. Nursing history is a systematic collection of information from clients, family, and significant others. Information is also obtained based on the nurse's observation. Information provided by the client is subjective. Hence, the nurse makes judgment of the client's health problem and needs by validating history with the conduction of a physical examination. Information usually obtained include biographic data, the chief complaint, history of present illness, past medical history, family history, including pattern of health care, and review of the body system. So we'll look at biographic data. This is the same as patient particulars. This type of information is commonly seen on the front index sheet of the public health facilities. Information is gathered on the following: the name of the patient, the age of the patient, address, marital status, occupation, religion, ethnic affiliation, excluded if racial interpretation is suggestive, next of kin, the informant, and date and time history was taken. Under the chief complaint, find out why patient reported to the hospital. Bates recommended that you quote exactly what the patient says. Some patients may be reporting for checkup or review, and this should be noted. For example, Mr. S.A. complains of headache, fever, and loss of appetite for the past 4 days. History of present illness. Give account of why patient is seeking help in a chronological manner. Note the onset of problem, where it started, manifestations, and any treatment taken. Outline the location, quality, severity, timing, setting, aggravating or relieving factors, and other associated problems. If patient is on any treatment, note the type of treatment, dose, route, and frequency of use. Find out any other remedies used by patient without embarrassing the patient. Past health history. Ask client about childhood illnesses, adult illnesses, mental problems if any, injuries, accidents, hospitalizations, surgeries, medication, prescriptions and over-the-counter drugs, home remedies, allergies, immunization, lifestyle, information on previous physical examination, Number of partners or types. Note the date and place of this event where applicable. Personal and social history. Ask patient about interests, sources of support, coping style, strengths and fears, education, home situation, sources of stress, important life experiences such as jobs, finance, and then retirement, leisure activities, religious affiliation and spiritual beliefs, activities of daily living, lifestyle that promote health, such as use of seat belts, diet, exercises, and etc. Processes of taking history. Prepare the environment, client, and yourself for the interview. Establish rapport. Invite patient's story using questioning type, closed and open-ended. Guide patient by determining kind of information needed. Probe for details where necessary. Demonstrate empathy and a positive interactive environment. Silence enables patient to think about what to say. Attentive listening portrays the nurse is interested in what the patient is saying. Conveying acceptance is another way to show you are listening without making judgment. Probe helps to clarify client statements. Paraphrasing validates what client actually means. Clarifying ensures avoidance of misconceptions and misrepresentation of facts. Often information helps to clarify doubts and reduce anxiety. Summarizing highlights major concerns of the patient. After history taking, you move on to physical examination. And here we are going to assess from head to toe. The requirement for physical examination, here you will need to provide privacy, a clean trolley with the following items: a spatula, examination glove, a stethoscope, a lavender perfume curry powder, sugar or salt, alphabet or shades of color, bell, a clapping sound with hands, torchlight, horoscope, a glass of water, comb, a patella hammer, pins, nurse's notes, and then a pen. The nurse needs to make a quick visual and physical assessment of the client. It helps to identify the specific conditions or problems that the client will bring. The procedure for physical examination from head to toe. Explain the procedure to the patient, why it is necessary, and how he can cooperate. Discuss how results would aid in planning care or treatment. Provide privacy and wash and dry hands. Observe patient general appearance and body build in relation to patient's age and health. Observe the skin for lesion, pallor, and texture. Examine the size and shape of the head, the eyes for discharges, pallor, and jaundice, and then the shape of the eyelids, and then photophobia. Inspect the nostrils for patency, discharges, and abnormalities. Palpate and percase cyanosis. Inspect the lips for cracks, soreness, pallor, jaundice, and any abnormalities. Inspect the teeth for artificial or natural dentition, dental caries, and bleeding gums. Examine mouth for coated or fed tongue and foul breath, source of the palate. Inspect the throat for inflamed tonsils, sore throats, and swallowing reflexes. Observe for the function of various senses: touch, smell, taste, sight, and hearing. Examine the neck, size, and palpate for cervical lymph nodes and swelling, for example, goiter. Examine the chest for shape, size, and auscultation for any abnormality. Examine the breast size, shape, lumps, nipple, crack, and discharge, and also the axillary for the lymph nodes. Inspect the abdomen for scar, lesions, linear alba, and palpate for distension, retraction, rigidity, and observe for visible peristalsis. Inspect the back for scars and kyphosis. Inspect the genitalia for inflammation, discharges, swellings, and lesions. And examine for pubic lice, warts, and anus for growth and patency. Examine the lower extremity for motor reflexes and nails for clubbing. Thank patient, make patient comfortable, wash and dry hands. Document your findings. For our next topic, we are going to look at checking blood pressure. This is a procedure that you often do on the wards and then at the OPD. So, for your reading, I expect that you review the procedure for taking blood pressure. But before that, we would like to know the purpose for taking blood pressure, and then you review the procedure on your own as an assignment. So, the purpose for taking blood pressure is to aid diagnosis, and then 2, to determine the client blood pressure as a baseline for comparing future measurements, and then 3, to monitor changes in the client's condition, and then 4, to assess client response to medical therapy, and then also help in the assessment of cardiovascular system after an invasive procedure, and then finally it helps to determine the client's hemodynamic status. So we move on to look at checking of height and weight. Measuring weight and height. The height and weight are measured to obtain baseline health status, assess nutritional status, calculate dose of some drugs, determine weight to height ratio, and then detect emerging disorders. Precaution. Ensure the scale is functioning well. Ensure precise measurement by using the same scale. Weigh patient at the same time every day. Ensure patient is wearing a light clothing and takes off footwear. Log scales with wheels prior to using it. Requirement for measuring weight and height. You need a scale, a chair or a bed, a tape measure, and then a sanitizer. Assemble your equipment before the procedure. Explain the procedure to the patient. Ask patient to empty bladder. Ask patient to change clothing if heavy. Ask patient to remove shoes. Assist patient to mount scale, making sure the patient is placed on the platform. Ask patient to stand erect. Note the reading on the scale. Place the height bar over patient's head and note reading. Ask patient to step out of scale. Assist patient to dress and inform him about findings. Allow patient to ask questions. Thank patient. Discard items appropriately. Where there are no height bars attached to the scale, obtain the tape measure and demarcate measurement unit on the wall. Ask client to stand erect at the demarcated area. Use a rule or a straight edge over the top of the head to determine height. For our final topic under this session, I'm going to look at assessing pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with tissue damage, described in terms of such damage or both. The experience of pain is complex and multifactorial. Pain involves emotional and cognitive processing but may lack a specific physical etiology. Acute pain occurs with intact nervous system by trauma, surgery, acute medical conditions, or physiological processes, and is rated to short period and the severity of damage and healing of injury or diseases. Chronic pain is a pain that persists beyond the expected time of healing or more than 3 months. Chronic pain is defined in several ways. Pain not associated with cancer or medical conditions that persist for more than 3 to 6 months. Pain lasting more than 1 month beyond the course of an acute illness or injury, or pain recurring at intervals of months or years. Chronic non-cancer pain affects 5% to 33% of patients in primary care setting. More than 40% of patients report that their pain is poorly controlled. Wow. Adopt a comprehensive approach to understanding the patient's pain. Carefully listening to the patient description of the many features of pain and contributing factors. Accept the patient's self-report, which experts state is the most reliable indicator of pain. Location. Ask the patient to point to the pain because lay terms may not be specific enough to localize the site of origin. Severity. Assessing the severity of the pain is especially important. Use a consistent method to determine the severity. 3 scales are common: the visual analog scale and the scales using ratings from 1 to 10, the numeric rating scale, and the faces pain scale. Multidimensional tools like the breath pain on the patient activity level. Associated features. Ask the patient to describe the pain and how the pain started. Is it related to the site of injury, movement, or time of day? What is the quality of the pain? Sharp, dull, burning. Ask if the pain radiates or follows a particular pattern. What makes the pain better or worse? Pursue the 7 features of pain as you would with any symptom. Attempted treatment, medication-related illnesses, and impact on daily activities. Ask about any treatment that the patient has tried, including medications, physical therapy, and alternative medicines. A comprehensive medication history helps to identify drugs that interact with analgesics and reduce their efficacy. Identify any comorbid conditions such as arthritis, diabetes, HIV/AIDS, substance abuse, sickle cell diseases, or psychiatric disorders. This can have significant effect on the patient's experience of pain. Chronic pain is the leading cause of disability and impaired performance at work. Inquire about the effect of pain on the patient's daily activities, mood, sleep, work, and sexual activity. Pain could also be assessed using NOPQRST, that is a mnemonic for N, number of pain, O, origin of pain or cause of pain, P for palliative or potentiates, Q for quality, R for radiation, S for severity or suffering, and C for timing and train. Pain management. The responsibility of the nurse in assessing pain using both diversion and pharmacological therapy in management and observing the client's responses to pain should never be ignored or postponed. Treatment of pain requires sophisticated knowledge of non-opioid and adjuvant analgesics and modalities of behavioral and physical therapy. In summary, we have looked at physical examination of a client. We also look at assessing weight and height and blood pressure. And finally, we also looked at how to assess pain in a client. For your reading, you have Latte, Tips on Practical Nursing Procedures, Lane Beckley, Guide to Physical Examination, Nicole, Barvin, Cronin, and Anderson. We have Essential Skills Handbook for Nurses and Midwives, Standard Procedure Manual for Nurses in Ghana. Thank you.